and welcome to the Nurse Rosa's Insights podcast. I'm your host, Rosa Hart, and joining me today is a healthcare celebrity, Dr. Erin Nance. Thank you so much for being with me today.
Oh, well, thank you so much for having me. And that's definitely the first time anyone has called me a healthcare celebrity.
I love that, even though before we started recording, you were telling me that you're going to be on TMZ. So if anybody counts
Well, I hope not TMZ, but TLC. If I was on TMZ, that would be a problem. That usually means I'm doing something notorious.
Well, me hearing the letters wrong might have led to me immediately thinking celebrity, but I did already feel.
Listen, I love celebrity gossip more than probably anyone on this planet. I had a subscription to Us Weekly for like 20 years, so I am all for it. I am not above that in any shape or form, but I'm doing a television series with T.
Okay, there you go. Well, not that you're going to limit yourself to any one platform because you've got over 100K followers on Instagram. You got a good TikTok following. You're a best-selling author of an actual book, and you are a founder. You founded your own app, which is kind of what we met discussing, Takeaway MD, which we'll talk about some more. But you're also an orthopedic, is it hand surgeon?
Yep, that is my day job.
With your own private practice, right?
Yep. My own solo private practice that I've had for over 10 years.
And you had your own podcast for a year, right?
Yeah, we had The Medical Detectives, which is still to this day much beloved podcast that I did with my friend Ann O'Brien. It was an incredible podcast where we would bring on patients who would share their stories of being misdiagnosed for sometimes upwards of decades. And we really just allowed them the space to share their story. And it's kind of like long form version of what I do on social media. And I just love that the podcast was 100% driven by the patients. And that's very similar to my television project with TLC coming up in July.
And what I have grown to love you for is what I was seeing on social media of how you've been, providing education, answering misinformation with real information. Your Instagram account is Little Misdiagnosed, which is also the name of your book, right?
Well, my TikTok account is Little Misdiagnosed. This is how you know I'm not a real influencer because I have like 10 different screen names or usernames. So I apologize for, making this hard on everyone. But my TikTok account, which is my main account, I have like 1 million followers, is Little Misdiagnosed. That is also the name of my book. But on Instagram, my Instagram is Dr. Erin Nance, like spell out the word Dr. Erin Nance. Right. And then to make things even more confusing is I just joined Snapchat as part of their creators. Yes, as part of their, big creators. And I'll be Erin Nance MD. Okay. So pretty much I made it as difficult as possible for anyone to find me. But when you see my face, you know you found it.
Right. And one thing that I think helped you go viral really quick was you solved a medical mystery in like literally seconds when other people couldn't in years, right? Do you want to tell us that story?
Yeah, that was really, I had been on TikTok for a while as the hand doctor and actually still have the hand doctor channel. But I had specifically tried to learn how to make viral videos, but I would just talk about this is the day in the life as a hand surgeon. These are the common hand problems that I see. And then someone sent me a DM and said, I know you'll never see this, but I'm desperate. I have had 10 years of fingernail pain. Nobody can figure it out. I've seen 5 doctors. They tell me nothing's wrong with me. But I swear if I just brush my fingertip against something, I'll jump to the ceiling. And I just, I don't read a lot of DMs, but I happened to catch this one. And I said, because I couldn't help myself, I said, out of curiosity, do you have a little blue dot under your fingernail? And she wrote back immediately, I do. I said, listen, you're going to ask your doctor to get an MRI of your finger. It's going to show you have something called a glomus tumor. You're going to find a hand surgeon. They're going to take it out and you'll be cured immediately. And then 6 weeks later, I got another DM saying, oh my God, Dr. Nance, I got the MRI and showed I had a glomus tumor. They took it out. I'm completely cured. Thank you so much.
Oh,
And, what she didn't realize is that if you go onto Google and you put in like PubMed glomus tumor, my name or my maiden name, Erin McDermott, comes up because I'm the world's expert on glomus tumors.
of
But
all the random
okay, but correct. But she didn't know that. And, somehow the algorithm really kind of like connected us. And that's what
What?
got me thinking, like, how can we do that, but at scale, right?
Yes.
How can we match people who have very specific problems with the people who we know have the answers? And it's a very difficult position for patients to figure out who is that right person who has the answer. Because what we've done is set up a system where, okay, my joints hurt. Well, does that mean that I go see an orthopedic surgeon? Does that mean I go see a rheumatologist? Does that mean I go see a physical therapist? Does that mean I go see, an immunologist? And one of the hard things that I tell patients is that if you see a clinician and they do not know what's wrong with you in the first 30 seconds, they are not going to help you. And that is just the way it is. All right. I would love to say, okay, that doctor is going to really think about it and go home and think about it. No, they're not. And it really is, what can they do in the confines of that 15 minutes that they have with you, which means that they have to listen to you. They have to come up with the diagnostic, criteria. Am I going to do blood tests? Am I going to do CT scans? Am I going to do whatnot? Make the diagnosis and then come up with a plan all within 15 minutes. That is very difficult for things that are not just strep throat.
Right. If it's not super routine, something they see every day, or something they're the world's leading expert on.
Correct. And listen, if someone comes into my office and they say, oh my gosh, I, wake up every night, my hand, it feels like it fell asleep, and my thumb and my index finger, they're burning with pain. Okay. That is carpal tunnel syndrome, right? I know you have carpal tunnel syndrome. All right. So I know that answer. But you may go to your primary care doctor and they may think, oh, maybe you have a pinched nerve in your neck, or so. It's really about how can we get the patient to the person with the right answer faster.
Yeah, definitely. And so that's what Takeaway MD can do in some ways, as far as disseminating that knowledge that is able to be communicated more generally, right? Like, I'm sure there are some enigmas you come across where it doesn't fit in your differential as much and you have to search, right?
Really, for me, it is about pattern recognition. And for a user, right, for them, it's not to say, okay, I saw this video and I think this is what they have. The whole point of Takeaway is to empower individuals to have better conversations with their doctor. And because all the content comes from credible sources, when you have that conversation with your doctor and you say, hey, I heard Dr. Nance talking about there's a condition that looks like carpal tunnel, but it's a little different, and it's something called amyloidosis, right? That physician may not even have heard of amyloidosis, right? But it gives them the language.
Yes.
It gives them the credible source. And then perhaps when they talk to their doctor, they may think, I've never thought about amyloidosis. Let me see, like maybe I should get an MRI to rule out amyloidosis,
Exactly.
right? But if that doctor does not know what amyloidosis is, you are never getting diagnosed with amyloidosis.
Yeah, they're not even going to know how to find it.
Correct.
Yeah, exactly.
Correct. And I think one of the biggest issues is you don't know what you don't know, especially as a patient, but it's also as the expert. Sometimes you just that doesn't even cross your mind, even though we have done all the schooling and we have seen all the patients, right? For many doctors, some of these more rare diseases, you're only seeing once a year or once every 10 years. But that doesn't mean as an individual patient that you're the only, right? There are some diseases that they're not rare, they're just rarely diagnosed.
Oh, yes. So true. Like, I feel like so many more people now are being diagnosed with Ehlers-Danlos syndrome, which is not that common, and definitely not common to be diagnosed over the age of 18. But I'm meeting so many adults who are getting diagnosed with it now because they're disseminating the information about what to look for and who to ask these questions to and how to find doctors who can assess you for it and test you for it.
Yes. And with Ehlers-Danlos, there's actually going to be a very large shift in diagnostic criteria. Next year, they're coming out with brand new diagnostic criteria.
Really?
So you have to be very careful about, there are 13 different subtypes. The majority of people have hypermobile Ehlers-Danlos. All of them, except for the most common one, have a genetic marker, but the most common one, hypermobile Ehlers-Danlos, does not have a genetic marker. So we try and be as specific as possible. But I think that the current diagnostic criteria is not adequate to really capture the large percentage of people who do have Ehlers-Danlos. And hypermobile Ehlers-Danlos is not rare at all. Again, it's more rarely diagnosed problem.
Exactly. That is what it seems like. So I'm encouraged to hear that they are getting an update. So hopefully more people can get help.
And that's the whole goal, is really the criteria, something called the Baton score. That does not take into account many different, we call medical comorbidities. And because of that, if you, let's say, and I'm talking about hypermobile EDS for these comorbidities, but if you are a woman who has dealt with IBS her whole life, you should stop and think about, do I have Ehlers-Danlos? Okay. Because, for example, if you think of Ehlers-Danlos or hypermobile Ehlers-Danlos as flexible joints, right? Stretchy skin. Well, what happens if your intestines are too stretchy?
Whoa.
What happens when your aorta is too stretchy? So it's about thinking about the connective tissue disorder beyond just the bone and joint issues.
Yeah. Which you would be an expert in, the bone and joint issues as well, and the hand. Especially.
But I will tell you that orthopedic surgeons, we do not, as a group, claim Ehlers-Danlos or hypermobile Ehlers-Danlos as a condition that we generally treat, because we do not have orthopedic solutions for that condition. And it's something, I just had this conversation yesterday with a patient. There are a lot of conditions, and patients don't even realize this, that are owned or not owned by certain specialists. So, for example, foot and ankle is a subspecialty of orthopedics, okay? If you have a diabetic foot ulcer, a foot and ankle surgeon, orthopedic surgeon will not treat you, okay? That's being treated by a podiatrist, potentially a vascular surgeon. So kind of the subspecialties have decided, well, this is what we treat and this is what we don't treat.
But if it leads to amputation, for example, then it might progress to need a foot and ankle surgeon, right? The podiatrist,
they wouldn't even do the amputation.
Would the podiatrist be the one ending up doing that? No,
probably the vascular surgeon.
The vascular surgeon. Well, they would need to take care of those blood vessels. Make sure you don't.
So as orthopedic surgeons, we do amputations, but specifically for that reason, they are not the go-to specialist to see. And so again, and you could make the argument, because who is the population that typically has diabetic foot ulcers and potentially, I would say that is in general not the highest paying population. And so to me, it's no wonder that orthopedists did not raise their hand and say, I would love to treat this patient population.
Well, I appreciate your candor.
Yeah. I mean, people should know how things are run. There's no logical reason why a foot and ankle surgeon shouldn't be able to take care of a wound on the foot. That's well beyond our capabilities and our scope.
Well, I really appreciate your curiosity and leaning into things that are mysterious to most people, even if it's not in the realm of things you necessarily own, because you're looking up or researching into all these different diagnoses in all kinds of different areas. Like, what would you say is a case that you talked about either on your podcast or on Instagram that's like the furthest outside your comfort zone?
To me, to be very honest, almost everything is connected. And it only requires a bit of curiosity and interest to be part of a case. There are some things that are beyond my technical capabilities. Like, for example, if I if I help diagnose someone who has hypermobile Ehlers-Danlos syndrome, and it ends up that they have mitral valve prolapse, I cannot do a heart stent, right? Or I cannot do a heart valve replacement. That is beyond my technical capabilities. But can I say, hey, you're telling me that you've had a murmur since you were a child? Has anyone ever worked you up for mitral valve prolapse? Okay. I'm a hand surgeon. Why am I the first person telling you that you probably have mitral valve prolapse and may need a very serious heart surgery?
Right. If somebody sees a heart murmur, you think they would go see a cardiologist and get that worked up and see if there's anything that needs an intervention.
But even cardiology may not be connecting the dots and think that the murmur is caused by an incompetent valve, because they don't realize that that patient has hypermobile Ehlers-Danlos because they're just treating the murmur.
I guess in my mind, like, I don't work closely with a bunch of cardiologists. I work with neurologists, right? So I am more familiar with like the processes in that zone. But so when somebody has a heart murmur, they don't work them up to find out if it's something serious causing it. They just assume what it could be.
For many patients, it's something that when they were either a child or, it's just like picked up, and they will just make sure that it doesn't progress or there's nothing, else, that maybe they get an EKG at some point, maybe they get an echocardiogram, that would be probably the gold standard.
Yeah.
But no, for most people, I would say for many people who have been diagnosed with hypermobile Ehlers-Danlos, they're not getting that type of workup.
Well, yes, I've become more intimately aware of the lack of workup that they get, because anytime that's suspected, people really like to pass them around like a hot potato and nobody wants to own it. So I'm hoping more people will be comfortable owning it if there is diagnostic criteria that makes it less mysterious.
And even yesterday, I had a patient who, came in with hand pain. That makes sense. You're going to see the hand surgeon. We did a diagnostic and therapeutic cortisone injection for a potential trigger finger, which she had very little response. And so I said, you do not have a mechanical cause of trigger finger, right? My job as the hand surgeon is to treat mechanical causes of trigger finger and potentially do surgeries. So I know she would fail as a surgical candidate. And so she has now gone beyond the technical capabilities that I'm able to offer her.
Then you refer out to.
Correct. So then we have to decide, well, now you are having pain, from your underlying hypermobile Ehlers-Danlos, probably component of MCAS. And I think there are more ways to treat pain than just pain medicine or anti-inflammatories. And now we're really starting to understand the effect of just the immune system in causing pain.
Because of like inflammation?
Not just inflammation, but direct release of immune-mediated chemicals. So histamine, right?
Okay.
I mean, there was the whole kind of viral trend of women taking Pepcid and Allegra. That was kind of a OTC MCAS, treatment regimen. And again, it's because these individuals were not getting any answers from the physicians they were seeing.
Yeah.
And so they were listening to other peers who were saying, hey, I started doing, this combination of over-the-counter medicine and it really helped me. And that's kind of the beauty of over-the-counter medicine, is that this is medicine we have deemed to be fairly safe. And this is something that you could take control of in your own hands.
Yeah, there are pros and cons to that, aren't there? And so what are you most excited about in this stage of the app development for Takeaway MD, and the way it's going to kind of democratize this information that otherwise might be gatekept behind appointments that might be really hard to get with specialists, or shoot, sometimes people have to wait 3 months to see a primary care provider.
Yes. Patients live their life 99.9% in between doctor's appointments, right? So even if you go to see your doctor, you're not able to benefit from the entire, knowledge that that doctor has about your condition. That really is, part of building takeaway was just to, it's almost like if you had a best friend as a doctor, what they would tell you. And so that really was the first, I would say the first focus of the app was the media portion of it and doing all this medical education. And now kind of our second phase of the app is helping to connect users who have the same symptoms and conditions so that you can actually learn from your peers.
Yes. Peer mentorship is so important. I've seen that a lot in the stroke space. It's especially just encouraging and relieving to know you're not the only one, or if somebody's further along in the journey than you, to give you hope that it can get better.
Yeah, I would say the number one comment on especially my early videos where I did the 31 for 31 series, was that people would say, I feel less alone, which is amazing. Because again, you may have a wonderful family, an incredible group of friends, right? But they don't have what you have. And so it's very difficult to have that, these conversations with people who just, they don't understand. They're very well intentioned, they're very supportive, but at the end of the day, they're not going to be able to provide you that insight that, listen, for example, if you've had breast cancer, there's no one you trust more than another woman who has had breast cancer.
Yeah.
Right? And it's not to say that their journey will be your journey or what their treatment was will be what works for you. But I think the more data points you can gather from people with lived experience really can only be helpful. And when we first started the Takeaway MD app, we had a beta group for over a year. And the overwhelming thing that they wanted was help us help ourselves.
Yeah. They don't want to have to wait on doctor appointment after doctor appointment.
No.
But trust is so important. And I think a lot of trust has been broken because people feel like their doctor, if they don't know the answer, is like gaslighting them and being dismissive. Do you feel like that is an accurate assessment, or do you feel like that? How do you feel about the term medical gaslighting?
There's a complete disconnect between how patients are feeling and how doctors are perceiving the interaction. Because from a physician standpoint, they're thinking of it in terms of what is my job, right? My job is to make sure you're not dying, make sure I didn't miss anything that's hurting you, and hopefully to give you answers and come up, with a pathway for success. If they feel like they did not find anything wrong with you, in their mind, that is a successful result, right? But to the patient who shows up to hear, oh, good news, all your labs are normal. Good news, your MRI is normal. That is very dissatisfying.
Yeah.
Okay.
When you feel like something is wrong and you still don't know why.
Correct. So I think you have to understand that as a physician, you could be doing the workup and you could be, examining them, doing everything that you would be normally doing. But to the patient, if they don't get an answer, that's not a successful appointment.
Exactly. That just means they have to keep looking.
Correct.
It's extended their search.
Correct. And for most patients who I, will say, if you feel like something is wrong and a physician tells you, I can't find anything, everything looks normal, that means that they have not found out what's wrong yet.
Yeah. It doesn't mean that they don't believe that there is a problem, right? It just means they don't know where to look next.
I think the vast majority of physicians do believe that patients have something wrong with them. Okay. But if you cannot measure it, then it doesn't exist. And that's why these terms functional neurological deficit, right? Functional, IBS. I'm glad that the terms exist so that we can at least tell a patient, I believe something is wrong with you, or whenever you hear the term idiopathic, anything.
Right.
Okay. I have a love-hate relationship with these terms because the problem with those terms is that they lead to dead ends.
Yeah.
When I give the IBS example all the time, if no one has considered connective tissue disorder, hypermobile Ehlers-Danlos to be one of the causes of IBS, you don't have IBS yet.
Because you have to eliminate that as a potential cause, right?
Correct. Correct. And that's for many different conditions. So yes. And another kind of big, I would say, thing that I talk about a lot on Little Misdiagnosed is this interplay between mental health and physical health, and simplifying a lot of conditions to just, oh, you have anxiety or you're depressed. Well, a lot of medical conditions will make people anxious,
Right.
will make people feel sad. All right. That doesn't mean that you have generalized anxiety disorder. That doesn't mean you have major depressive disorder. Okay. And again, these are leading to dead ends before the physical diagnostic journey has been completed.
And maybe masking symptoms with treating the anxiety and depression, but not finding the root cause.
Correct. Or just misdiagnosing, period. I mean, there's a whole generation of women who were diagnosed with bipolar, who were put on lithium, who really had ADHD or autism ADHD.
And people just didn't think women could have that.
Correct. Because if you close your eyes and you think, who has ADHD? It's a little 8-year-old boy who can't sit still.
Right. So that diagnostic criteria can really come into play into making a difference and helping people get the help they need. Yay.
Yes. I mean, I just last night, having dinner with a friend from high school who had just flown back from Switzerland. I said, oh, what were you doing? She said, oh, I was at my aunt's funeral. I said, oh, I'm so sorry. And she goes, that's not the crazy part. She said, the uncle died. And on his funeral day, the aunt died.
Well,
I said, oh my God, what happened? She said, right before the funeral started, she started having pain in her neck and difficulty breathing. They took her to the hospital and the doctor said, well, she's really upset because it's her husband's funeral and she's under a lot of stress. No, the woman was having a heart attack and she died.
Well, of course. So they weren't also doing an EKG and drawing the CKMB and troponin at the same time while saying, yes, she's also stressed.
They drew no labs. They drew no labs and did no EKG until it was completely too late and she's in the resuscitation room.
Didn't Elizabeth Banks show everybody in the world what it looks like when a woman has a heart attack? I mean, that really seared it into my brain. Did you see that video she did with the Heart Association? Well, okay. I'm going to send that to you after we are done here because she should have got an Oscar for that. Also, it was just so succinct. Yes, women and their missed symptoms. Well, before we go any further, I want to ask you the question that I ask every guest on the Nurse Rose's Insights podcast. So, Dr. Erin Nance, if you were given a grant for $1 billion to meet a need you see in healthcare, how would you like to see it used strategically to have the most sustainable impact?
I would just expand the work that we're doing on Takeaway Connect, which is connecting individuals with other individuals who have the lived experience, and also to be able to expand it because there are so many key learnings that we can learn from people with different conditions, or even just take the field of oncology, right? If you were diagnosed with breast cancer and are starting Keytruda, you could learn a lot from someone who had lung cancer and was on Keytruda, right?
Exactly.
And so the more that we can build bridges and build connections between the diagnoses, I think that is the most impactful and the most sustainable way to educate the population.
Yeah, and people learn from people. I mean, on the one hand, in marketing, they say people buy from people. But even when it comes to learning, you're buying into an idea, right? So that relational aspect of trust and knowing that this person understands what you're going through is so key to actually making these breakthroughs.
Absolutely. Listen, there has not been an innovation in peer support since Facebook groups came out 20 years ago. And I can tell you that no one wants to be on Facebook. All right.
There are so many people who are on Facebook just because that's where the group of the PTA is, or
Correct.
the group of the people who maybe they have this diagnosis, and where else are they going to talk to those people? And so they have to hide their eyes from the negativity.
Correct. So we can be doing such a better job with, on the back end, connecting people. When I, again, spoke with the beta testers for Takeaway, and they were telling me about their experience with Facebook groups, they go, it's like the sick Olympics. It's run by these admin overlords who feel like they have power over these groups. And my whole point is there shouldn't be any gatekeeping. There shouldn't be, right? You should be able to be connected with someone who is interested in either giving their experience or asking a question. And you should be able to get multiple perspectives, right? Not every perspective you may agree with or you may find useful. But that's the point of the connection.
So how do they make the connection? Is it like a dating?
We know on the back end everyone's symptoms and conditions. And so how it will work is that, let's say you have endometriosis and you're about to undergo surgery for endometriosis. You can ask, we're building our AI agent's name is Maura. Maura, is there anyone on Takeaway right now who's had surgery for endometriosis? And then we can see on our back end, we have 30 people in the app right now who have endometriosis. And we will ask them, hey, we have a user who wants to ask a question about having surgery with endometriosis. Would you be willing to speak with her? And then it's a double opt-in process. And then we make the almost like an old school AIM chat. And so we're able to make that connection. But then as part of joining this Takeaway membership is we are learning from your conversation so that the learnings don't just die in that chat. Okay. That's the whole point, is we want to extract all of that peer experience and then share that with the entire community.
That's going to be a lot of golden nuggets there.
It's almost similar to Reddit in that there's a lot of power in those Reddit threads, right? And I think if we take a scientific approach to peer learning, that in the end, that's what's going to be most valuable.
I am absolutely enamored with what you are building here. It is just so exciting because I talk to people every day who are struggling to navigate the system of healthcare, and I'm fighting to advocate for them to get access to really specialized information. But so creating anything to democratize that process just gives me such a sense of relief that work is being done. So thank you for what you're doing. And I'm sure a lot of more people are going to want to get involved. So if someone is in healthcare or has a condition that they would like to talk about on Takeaway MD, what is the best way for them to get connected?
So right now we are just launching the Takeaway Connect membership. I think the website is live now where you can kind of be one of the first people on the waitlist to join the membership. But if you go to takeawaymd.com, there's a section for Connect, and you can be one of the first, users on our waitlist. We already have 65,000 people on Takeaway MD. So, and we have it segmented by condition. So we can, we know that we've got 10,000 women with endometriosis and 8,000 people with POTS and 5,000 people with MCAS. And, we're really looking to have, for me, it's important to support rare disease, to support rarely diagnosed conditions, but also even the common conditions, they may be super common, but you don't know anyone who has that. So it doesn't matter to us really the size of the condition. We're most interested in making the connections.
So beautiful. I love it so much. And then we talked earlier about where people can find you on social media. So I will have your handles to your various accounts in the show notes.
I know, whichever is your social media du jour. But although I do know that there is a fake Facebook account that has 500,000 followers. So don't follow that one.
No, you can't get that taken down?
Oh, we've tried. We've tried many times.
Well,
But
imitation. They say imitation is the highest form of flattery.
I know. And I have such wonderful users who will send me messages on Instagram saying, I think someone hacked into your Facebook account. And I have to tell them that I never had a Facebook account and it was a fake account. But it looks real. Same thing. There's a YouTube account, Dr. Nance Official, with a couple 100,000 followers. It is not me. Has never been me. So it's.
Do they repost your content?
Yes. They all steal my TikTok content. My TikTok content is always my original content.
Okay.
But for many people, and this is part of why I built Takeaway, if you're not on TikTok, I cannot convince you of the benefit of being on TikTok. It's just a non-starter. But it doesn't mean that there's incredible medical education happening on TikTok. The doctors are doing a phenomenal job. But that's part of why I built Takeaway, is so that the users can have a safe and trusted place to get credible health information.
Yeah.
And my goal is when a user goes to their doctor and says, oh, well, I heard Dr. Nance talk about this on Takeaway MD, that they don't roll their eyes.
Hopefully.
And it's very different from saying, well, I heard someone on TikTok say this.
Yeah, it's amazing the legitimacy that a platform will give or take away.
Yeah, absolutely. And so, when I decided how to build my, next venture, I decided I was not going to tie my success to an external distribution network, and that I had to own the distribution network in order to control how the content was, distributed. And for the point of Takeaway is that we don't focus on virality at all. We actually have no view counts on any of the videos. We have no like counts on any of the videos, because for us, the measure of success is not how popular a video is. The measure of success is how impactful was this video to a user who has the needs and symptoms that this video talked about.
That's perfect. A match made in heaven or on an app.
Yeah.
Love that. And so thank you so much for coming on the Nurse Rose's Insights podcast to share this. And on this show, this is where I interview healthcare stakeholders, which could be any human person, because we all have a stake in healthcare. And you make me feel more confident in those stakes. So thank you for.
Well, thank you so much for inviting me. And it really takes all parties coming to the table in order to make this work. We have to work with our industry partners in pharma, in life science, because we need new innovations, we need new solutions. And so, we have to show this is where the investment goes. This is because investment is another just determination of what matters. All right. And I think we have determined that male pattern baldness, has mattered too much for too long. And we have many other conditions which deserve funding.
Exactly. Especially for women.
Absolutely.
So for our listeners, if you've enjoyed this episode of the Nurse Rose's Insights podcast, please be sure to like and subscribe wherever you're listening, or if you are watching on YouTube, leave us a comment and let us know if you learned something. And if you know of another health innovator with ideas on how we can build a better healthcare, be sure to point them my way so I can spotlight them. And I'll see you in the next episode.